Okay.
All right. Hi, everyone. Thank you so much for coming out to our What You Need to Know About series. Today we'll be talking about fibroids. So we have Dr. Ruth Arumala. She has a patient-centered approach to healthcare. She believes in treating people, not their conditions. She has a passion to not only provide excellent medical care, but to empower women to make healthier choices that enable them to live a happier, more fulfilling life. As an obstetrician gynecologist with a practice in Mansfield, Texas, Dr. Ruth Arumala provides evidence-based medical care to women of all ages at all aspects of their lives. Dr. Arumala specializes in the medical and surgical management of fibroids, PCOS, sexual dysfunction, pregnancy, and menopause. In addition to private practice, Dr. Arumala serves on the executive board of Texas Health Mansfield. She has won several awards that demonstrate her exceptional clinical skills and service to her community, including 2020 National Minority Quality Forum's 40 Under 40 Leaders in Minority Health, 2020's Patient Preferred OBGYN Menopause Specialist, amongst many other awards. Armed with her varied experience in medical training, Dr. Ruth Arumala, DO, MPH, NCMP, serves as an assistant professor in OBGYN at TCU UNTHC Medical School in Fort Worth, Texas. And given her passion for all things women, Dr. Arumala also serves as the entertaining host of the Pretty in Pink podcast. From fashion to fitness, fibroids, and faith, Dr. Arumala interviews inspirational female expert guests who explore a broad range of topics that affect women, which is how I found her. So without further ado, here's Dr. Arumala.
Hi, everyone. Thank you so much for having me. I'm so excited to talk about my favorite topic, a topic that I take care of about 70% of my practice. And so I'm going to start off really talking about a couple of patients I've had in the past 3 months. So actually probably 2 months. So I'm going to share my screen with you. And so it's loading. Okay. So I want to talk about uterine leiomyoma. So fibroids are a colloquial term. Leiomyoma is the medical term for fibroids. I will get into why. Another name is called just a myoma. And I want to share with you what they are and why you should care about uterine fibroids. So the first person I'm going to talk about is Miss Near Syncopal episode. So this is a 34-year-old. She is a G0, meaning she's never been pregnant. And she had a recent episode of extremely heavy bleeding. Literally, she was on the phone with her friend and heavy bleeding. She just started bleeding out of nowhere, okay? And the bleeding was soaked through the couch she was sitting on, and she jumped up, ran to the bathroom, clots kept coming, okay? And then she obviously was like, let me wear a pad, a tampon, something. And so she wore a pad and she soaked through the pad in about 15 minutes. And so she decided, okay, I'm going to wear a pad and a tampon. And that was 20 minutes. And she dealt with that for about 3 days, nonstop. And so she continued doing her day. She just started doubling up on pads and buying ultra pads, ultra tampons. And this was not even her scheduled period. And unfortunately, or fortunately for her, she hadn't been on a regular schedule because she was suppressing her periods with the NuvaRing, which is a form of birth control that goes in your vagina, has both estrogen and progesterone. She knew that she had fibroids, found out 9 months prior. And so with her obstetrician, or her gynecologist, she decided that she was going to suppress her periods. And that was what she was doing, which was working until that fateful day. During her schedule, she contacted her. She was hoping it would go away, it would get easier, but when she was in the process of working, she almost fainted. So at this point, she was like, no, you gotta call my gynecologist, AKA call her gynecologist. And her gynecologist told her, all right, we'll put you on what we call an OCP taper. She started an OCP taper, which is combined birth control, high dose, and you keep going lower and lower till you get to a certain point. And she started that and her bleeding stopped. But she experienced another near fainting episode, and then another one. So she went to her primary care physician who drew her blood, and her hemoglobin was 5.8. Her hematocrit was 18. Normal hemoglobin is between 12 and 14 for a woman, and less than hemoglobin of 7, we transfuse. So her primary care physician called her, told her to go to the operating room and get transfused. So this is the story of Miss Near Syncopal episode. And this is what her ultrasound looked like. So this is her actual uterus. And this is the fibroid on ultrasound. This is the transvaginal ultrasound. You can tell because this is a little bit smaller. A transabdominal ultrasound has a wider probe, and this tends to give you a more accurate picture when it comes to an ultrasound, and we'll talk about how to look at fibroids. So that's Miss Near Syncopal episode. Misrecurrent UTI, a 36-year-old, also never been pregnant, came to her new gynecologist, AKA me, excited she was going to see a gynecologist because she had been going to the acute, the urgent care centers every time she had a UTI, and they would give her medication, and the medication would work, and then 2 months later, she'll need another one. And so she came to me for recurrent UTIs, but I don't manage urine. I tell my patients I have focused on one hole. There are 3 holes there. There's the urethra, there's the vagina, and there's the anus or the rectum. I am the vagina. And so I was like, nah, ma'am, not me. Have a good life. Call me if you need that other hole. So she told me, well, Dr. Arumala, and she actually came to my office, and I went out and met her, and I said, I don't manage this. And she said, Dr. Arumala, but I'm 36, I'm married, I've been trying for 3 years to get pregnant. I want you to see me for fertility. I said, I would love to see you for fertility, but fertility I take a whole hour. So let's reschedule, go see a urologist. Here's his card. I'll see you later. She went to go see the urologist, and the urologist basically did an ultrasound and told her that she had a huge fibroid. And really, it was the huge fibroid that was pressing down on her bladder, that was making her feel like she had to pee all the time. So I saw her again, and I took her to the operating room. This is a picture from our surgery. And this is about 4-centimeter fibroid. This is a pedunculated fibroid. She also, if you notice, there's a little bit of a hump here. She had a fibroid right under that. So that fibroid is about 3 centimeters. So together there's a 7-centimeter fibroid, which was what was reported on the ultrasound, that was pushing, her bladder is right up here, which is pushing out her bladder. So every time her bladder was semi-full, it would push, and she'll feel like she needs to. So she wasn't actually having infections. She was having no space. If you look over to here, you'll see a blue dye. That's not blood, that's a blue dye. That's what we call chromotubation. So when I do surgery on women who want to have babies, I check to make sure their tubes are open, and the gold standard is chromotubation. So it's an injection of a blue dye into the uterus, and we see if it spills out into the tubes. And so hers did on both sides, thank you, Jesus. And so she does have patent tubes or open tubes on either side. I actually did this case yesterday. And we had a surprise. So that was the previous fibroid taken out that you saw up here. There was an even bigger fibroid, which is right here. It's bigger than her uterus itself. It was 11 centimeters. Normal uteruses of a woman that hasn't had a baby, that's 35 years old, 36 years old, is 5 by 6 by 7. So 7 centimeters would be the biggest size. Hers was about 7 centimeters. This is an 11 centimeter fibroid. So this is the base of it. So I took that out. And this is what it looks like when it's taken out. And I have sewn this. I did this all laparoscopically yesterday. Her fallopian tubes are either side. Her ovaries are poking out here. This is her uterosacral ligaments, and the vaginal cuff where the vagina and the cervix is a little bit below this. So this is the back of the uterus. I'm going to talk about another patient, Miss Early Satiety. Miss Early Satiety was a patient, she was a 37-year-old, also a G0, who had been married for 20 years. She got married, 20 years. She got married at 17. Never been pregnant. Husband never has gotten anyone pregnant. And I should say with this patient back here, her husband also had abnormal sperm. So there's always infertility. Fertility is a couple's disease. So there's always the woman and the man. And so there's always a male factor that has to be considered, even if there are fibroids, even if there's a problem that's identifiable by a woman, because having one problem doesn't preclude you from having another problem. So Miss Early Satiety, again, 37-year-old, married 20 years, has never been pregnant. Husband has never gotten anyone pregnant that she knows of. But she said that her major issue was that she would eat a little bit, like this much, and she'll be full. And she was like, had a BMI of 16. A lot of people know underweight, the BMI is 17 or less. So very small, but had a protruding abdomen. She had seen 4 prior physicians who had given her an 80% chance of a hysterectomy. She still wanted to have babies. She actually had a pretty good ovarian reserve. And so I actually had interviewed somebody to come over. I'm the head of the OBGYN department at a new hospital. So we had interviewed an OBGYN who, in process of talking to him, he knew that I was a uterine fibroid specialist. So I was sent to her through him because he works in a large academic institution. And I think I should say this, one of the greatest honors for a practicing surgeon is for another surgeon in your field to refer someone to you. And so the patient came in to me, we reviewed her records, and this is what her MRI looked like. So this is where the umbilicus should be. It's kind of cut off. You can kind of see an indentation here and an indentation here. So this is how high above the umbilicus her fibroid goes. Her uterus is this tiny thing down here. And so that is how big her uterus is, okay? Her fibroids are. And this is actually not one fibroid. This is a sagittal view, meaning from the side. If you look at a coronal view, there's actually another one just like this there. So talk about another patient, misrecurrent disease. This is a 41-year-old G0, and notice there's a trend of a woman who is in a same-sex marriage. She came to me because of uterine fibroids. She had heard about me from her sister, who is my patient also, and she wanted to get her uterine fibroids assessed. She had had a history of a uterine artery embolization, which is a procedure done by interventional radiologists. And that is usually they access the uterine artery from either the wrist or the groin. I'm not sure exactly how it's done because I still am yet to watch one of those procedures, and I have plans to do that soon. But basically they use an MRI to guide the access to not just the uterine artery, but the specific branches that are serving the fibroid. And we'll talk a little bit about how fibroids grow and the natural course of their physiology. And basically, they try to occlude that blood vessel by using small microspheres. And the uterus itself has collateral blood supply, so you can cut off a lot of blood vessels to that fibroid, and hopefully the fibroid would shrink. Again, hopefully. So she had done the procedure 2 years ago, and I did an ultrasound, and the ultrasound was actually kind of muddy. I did not do the ultrasound myself, which I normally do. I sent her out to an institution, and basically, I think at that time, my ultrasound machine was having a problem. And she came back and they told me she had 5 fibroids. To my surprise, this is what I saw. Definitely not 5, more like 13. And so I ended up, and this was after she's already had a uterine artery embolization. The thing about uterine artery embolizations is they work if you have few large fibroids. She had multiple small ones and was having a lot of symptoms that included urinary frequency. She also has the desire to carry a child. She did not mind having an egg donor and a sperm donor. She was okay with having her partner's eggs. So this was kind of done for both. So we discussed kind of fertility and well, with the uterine artery embolization, although there have been case studies, and I think in the radiology journals, they talk about how you can retain your fertility. The American College of Obstetrician and Gynecology and the AAGL, which is our laparoscopic society, does say that, you know, we don't recommend uterine artery embolizations for women that want to preserve their fertility. However, it's a uterine sparing technique. So at this point, I counseled her, well, not at this point, but prior to coming here, I counseled her and she was okay whether or not she carried a baby. I told her about the assessment procedure, which we'll talk about, and it's a newer procedure. I did that procedure. This is kind of what the, it's an intra-abdominal ultrasound. So if you go back to this picture, this is the actual ultrasound touching the uterus. So that's different from an ultrasound from the vagina or from the top of the abdomen. And that was us, this is one of my assistants, that was us looking at the screen to actually see the specimen, and also looking at the ultrasound on this end and watching, this is me watching my probe going and treat the fibroid. Last patient of mine, she was 61 and she was still having heavy, heavy periods. Found me on a random, I think she found me, I have one paid advertisement for my practice, and it's at Kroger. On the shopping cart, as you're shopping, my little mug is staring at you and it says uterine fibroids. So she found me, and she came to my office. She was still having her periods. The average age of menopause is 51 years and 9 months. Sometimes it's also quoted as 7 months. But either way, she's 10 years the opposite, which could be normal, because if you're talking about an average, there could be someone that's 41, there could be one that's 61, but here we are. So we talked to her. She was so over her uterus. She told me I could take it up, that she would donate it to charity. And so we did a endometrial biopsy to make sure that she did not have cancer, because that's one way that could be prevented with heavy menses. But she never stopped bleeding, and this is what we saw. She had 22 fibroids in this uterus. There's still lots of fibroids in here. So there you go. She hasn't had a fibroid. She hasn't had a menses, and I took this out less than 6 months ago laparoscopically, also through 3 small incisions and her uterus. So she went home same day. She never called me with any problems. She's great. And I haven't even done her 6 weeks checkup, but she did call me recently to just be like, you're a lifesaver. Exactly why I love my job. So those are kind of stories about my patients. And so let's talk about it. What are fibroids? Where are they located? Who gets them? How do they present? How do people like me work them up? And then how do we manage them? That's going to be the crux of this. So what are they? So the way that I explain them to my patients are that they are the uterus itself has 3 layers. It has the skin on the outside called the serosa, And that was what you saw when you were looking at the fibroid, that pink outer, that is the serosa. The muscle is on the middle, and that smooth muscle, that's non-voluntary muscle, like striated muscle with your arms or your legs. And then the inside of the uterus is called the endometrium, or the lining of the uterus. So the myometrium is the muscle of the uterus, and all my patients know what a myometrium is. I talk to them like I'm talking to you, okay? Because every patient, and if you don't remember anything from me, every patient should be the CEO of their body. You just work for them. So they should know their body. CEOs know a lot about what's going on in their lives. They don't, or in their companies. I don't like the idea of us being paternalistic and telling our patients just morsels of information. We're supposed to empower them to make the right decisions for their lives. So I'll get off my soapbox and go back to talking about fibroids. And so basically fibroids, they have one cell that does not obey nature. Nature in any aspect says grow, reproduce, and die, right? Well, the myometrial cell will say, nope, I'm gonna grow and reproduce and grow and reproduce and grow and reproduce. It does not listen to the cell cycle that you learn in cellular biology, and it doesn't go into apoptosis. It just continues in that cycle, in that growth phase. And so that is why it's called a monoclonal tumor. Every single fibroid is made from one cell, and it's a smooth muscle cell. So why are they called fibroids? Because originally we thought fibroblasts was what caused fibroids. Fibroids are not fibrous tissue. They're smooth muscle tissue. So that's why we changed the name, or the scientific name is really myomas, muscle tumors. Oma is a tumor, myoma, or leiomyoma. But we had colloquially, they're already known as fibroids. So in my in my oral board exams, we cannot actually say the name fibroids. They're actually called myomas or leiomyomas, okay? And so you cannot know something is a leiomyoma until you look under the microscope and have deemed them to be world muscle tissue that does not have any atypical cells. So a myoma can include either a leiomyoma or leiomyosarcoma. A leiomyosarcoma, sarcoma, as you know, are cancer. So there is 1 in 325 women are going to have a myoma that's actually a leiomyosarcoma. They actually think that the incidence is a lot less, but that's what the FDA quotes. That's what I'll quote for you. But those are aggressive tumors that are cancerous. And that's actually why we don't morcellate anymore. And so that is what they are. Where are they located? They can be located actually anywhere in the actual uterus, and even on the broad ligament. The broad ligament is actually a skirt that kind of coats on either side. I have actually never taken out a broad ligament leiomyoma. However, I have watched lots of videos of them being taken out, and I'm praying to God that at some point I won't get there, because they're actually pretty difficult to do. But if my patient has it, I will. So they can be either on the top, like you saw that pedunculated one. The one that you saw on the top had a broad base, but it was pedunculated. It can be in the muscle. That's called a intramural, like right this one. A submucosal is one that goes into the endometrial lining. It could also be a pedunculated one. And then there could be a subserosal, which is right under the serosa, or the skin of the uterus. So they could be anywhere, okay? Who gets them? This is one of the reasons why you had me come, because fibroids disproportionately affect Black women. 80% of Black women can get fibroids and 70% of white women will get fibroids by the age of 50. So I recently had a 38-year-old, she's had a baby like 18 years ago. She wanted me to do a fertility workup on her, and I saw a pristine uterus. And me and my MA were like, oh my God, this is the most beautiful thing. I tell you, every day, I mean, everyone has fibroids in my mind. right? Like you come in with bleeding, you got everybody has fibroids until proven otherwise. So for me to see a beautiful, pristine uterus at 38, oh my God, it was like the most beautiful sight I have ever seen. So most women are going to have fibroids in their lives. There's a problem with this disproportion because Black women have them earlier and have more symptoms. The good thing is that we notice that we don't start to see women having fibroids prior to puberty. That would be case reportable. In addition to Black women having more incidence of fibroids, more prevalence of earlier fibroids, they also have, or we also have, more clinically relevant fibroids. So we tend to have bigger uteruses, we tend to have fibroids that are bigger, we tend to have submucosal fibroids. Those are clinically relevant, and we'll talk about why. And they always talk about fibroids in terms of Black women and white women. I had to actually look for the data for Latinx women and Asian women, and it's actually not very clear. They think that Latinx women and Asian women tend to be closer to white women. Why is the big question. When I figure out why, meet me on the Nobel Peace Prize stage. So how do they present? Majority of them are small and asymptomatic. The incidental, we usually find them on incidental imaging, like I had a patient who I was consulted in the ER for a patient who came with abdominal pain, which is very common when I was taking ER call a lot. There's very common to get this when I was a resident. And basically it's usually some older patient, postmenopausal patient who comes in with abdominal pain, which is usually diverticulitis or diverticulosis, something that ain't got nothing to do with me or my hole. And then they find an incidental finding of a 1 centimeter fibroid. A 1 centimeter fibroid is a blueberry. And it's usually calcified, meaning it's dead. So I go there and I say, hi, thank you for my $300 for your consultation fee. There's nothing wrong, okay? From my standpoint. So that's the majority. But then I've showed you different ways that it can present. Heavy bleeding that leads, conclusion of Miss Near Syncopal episode, she needed 3 units of blood because she was, down to hemoglobin at 5. The 3 units of blood brought her up to 8.4. She's great. And then with her birth control, she's no longer bleeding. You can have bulk symptoms. So bulk symptoms are pressure, pain, urinary frequency, like we talked about misrecurrent UTIs. You could have pain with intercourse. You could have pain just sitting there. You could have pain with your periods. You can actually have a uterus so big that it pushes back on your venous system and you end up having poor lymphatic return. So you have really large legs, you have increased risk of venous thromboembolic disease. So bulk symptoms. And the last category is reproductive dysfunction. As you notice, none of these patients have been pregnant. Some of them have never tried, but some of them have been also trying for 17 years. Not trying, but like not using any protection and having unprotected intercourse for 17 years. That seems to be a problem, right? So that's also considered reproductive dysfunction. So the major 4 categories are asymptomatic, they're just there, bleeding issues, bulk symptoms, and reproductive dysfunction. Those are major categories. There are a lot of other things like recurrent bacterial vaginosis. That happens a lot with women with fibroids. Don't understand why, but there seems to be a serous drainage that must have a different kind of pH that changes the pH of the vagina that causes you to have an infection. So how do GYNs work them up? Well, we always do a history and a physical. Being an osteopath, you better be good at doing the physical. Your fingers do the talking. And with gynecology, we do a lot of blind procedures. So that was one of the advantages I had coming in from being a DO, was because I was able to use my hands to do a lot of things. You could do a pelvic ultrasound is always the first step of actual imaging. We could do other types of imaging like a saline sonogram, which means that we are actually injecting fluid into the uterine cavity as we're looking. A hysteroscopy, so hys is the uterus, scope is a camera. That means the camera went into the uterus and looked and saw the fibroids. And then we can always do an MRI. Particularly, I do MRIs before I do minimally invasive OBGYN, or sorry, minimally invasive myomectomies. I do that routinely. So how do I manage? We manage them. It's actually okay to, if the patient does not have any symptoms, to manage them by surveillance. Surveillance always means an annual ultrasound. And I do, in my practice, I commonly do an annual ultrasound because I want to ensure that my patients don't have rapid growth or more than 1 centimeter growth per year, because that can be indicative of a leiomyosarcoma. And if they do have rapid growth, then I do blood draws that look for a tumor marker. The only tumor marker we have for leiomyosarcoma is LDH isoenzyme 3. And then we do symptomatic management. We try to deal with the bleeding, most of that. And that we could go down a whole, that's the management of abnormal uterine bleeding, which is like my whole life. So we can go down all the different options. We do procedures. We talked about the uterine artery embolization that the radiologists do. I do the Acessa and Sonata procedures are pretty similar. The difference is that the Acessa is done laparoscopically and the Sonata is done transvaginally or transcervically, so there's no incisions. But basically this is an ultrasound guided radiofrequency ablation of fibroids. So we use radiofrequency to try to shrink the fibroids. Acessa came into the market in 2015. It was most recently it was created by a doctor, I can't remember his name, I can see his face because I've met him several times, but it was recently bought by Hologic, so it's going to become much more popular. Right now it's very limited who is trained, and I'm one of the people that are trained in the Dallas-Fort Worth area. Sonata came into the market in 2019. I went to the first training in 2020. I actually came back from Sierra Leone and dropped my bags and got on the next plane, went to Atlanta, got trained right before the pandemic. I didn't know a pandemic was coming, so I'm not a prophetess, but that happened. And so hopefully we'll be starting to do Sonata soon. And then that shouldn't have a comma there. That was me trying to fix this at 4 a.m. this morning. And so it's just an endometrial ablation, which can be used also, not as effective as all the other procedures. And then a myomectomy is myoma muscle. Ectomy is the removal of the fibroid itself. And reconstruction of the uterus afterwards. And so that's what I showed you when I showed you my case from yesterday for misrecurrent UTIs. I took out her fibroids, reconstructed the uterus, or hysterectomy, which is the way that I showed you when I showed you Miss 61-year-old bleeder. And so I took out the fibroid, uterus, ectomy, removal of. So that's how we manage them. So I just want to tell you guys a little bit more about myself because that's the end of fibroids until you guys have questions. My story, I'm actually the first patient that you talked about, Miss Near Syncopal episode. That's me. So I almost passed out actually operating. I'm a fibroid slayer, and here I am with fibroids. So I know this topic very intimately. And so this is why I'm so passionate about fibroids. My practice is built around the fact that women deserve to have amazing care regardless of their insurance. And then I decided that while we were building my practice that I was going to create a love letter to all my future patients. And that's actually how I started the Pretty in Pink podcast. Texas Health Mansfield is a brand new hospital. I'm blessed with the opportunity of working to create a culture and atmosphere of a hospital that echoes the values. I don't know how I got here. This was a place that I thought I was going to be in 20 years and somehow got thrust in my lap 2 years after residency. Also new medical school that I wanted to be part of a medical school. I had actually applied to a long-standing medical school and they said I did not have enough experience, and TCU came to me. So I say all that to say that opportunities that are yours are not going to be something that you race over, you fight over. It comes to you. They're yours. They'll never pass you by. And then I also do a lot of contributing because my goal is I want to be able to touch lives of women I never see. So I work for a Ukrainian company called Flow Health. I do a lot of work for them, and that's the Flow app. So you might see my mug there, and a lot of the things that I edit or videos that I make for them. I'm also an advisor for PhD Feminine Health, which is a feminine health product line. I'm their chief medical officer. I work for Myovant. Myovant is a brand new company that's actually focused on uterine fibroids and prostate cancer. So they only really are talking about two medications, and they're in the process of creating a brand new medication focused on the management of heavy bleeding in women with uterine fibroids. And then I do my advocacy work through White Dress Project, which advocates for women with fibroids. So that's me, and I want you. All of this, we talked about fibroids. In like this is the fastest uterine fibroids. I'm looking at my clock over there, like, gotta go, gotta go, gotta go. But this is the fastest uterine fibroid. So this is not really about fibroids only. You're going to be a physician. You can do whatever you want to do, but I want you to find your purpose, because being a physician is just that. Okay, so what? What is your purpose? What is your passion? Where does your passion, your love for people, for yourself, your intellectual ability, and what you were created to do, where does that intersect with the need of a community? Find that and you'll be happy. That's it.
Thank you so much, Dr. Arumala.
That was really great. Thank you.
You're welcome. So I am going to stop sharing so we can actually communicate, and you guys are happy to ask questions. I don't know if there are questions already. I was yapping. So
thank you, Dr. Arumala.
You're welcome.
I'm scrolling through the chat.
So just to let you know, Dr. Arumala, we don't teach OB/GYN until the second semester. And so a lot of the terms you were using, it was a bit of shorthand, and they don't know those, like G0, P0.
We learned that in PD.
Oh, she did? So good. Yeah. And the measurement of the uterus, for instance, because she had said 5 by 7 by 5, or 4, I think. And that's something we do in PATH. We actually measure the uterus, and we let the OB/GYN know. So it's just some of the things that, you know, you guys are just not exposed to just yet. And the reason they don't do the abdominal hysterectomies unless they have to is because there's a lot of scarring. So, and the healing time is longer. And Dr. Arumala can explain it better than I can.
So let's go with questions. I try to actually talk to you guys because I'm not sure exactly what level you are. So I try to talk to you guys like I would talk to my patients. But again, I was also really, word racing. So if you have any questions, please feel free to ask.
For what? Sorry, go ahead.
Go ahead, Barkley.
So for one of your patients where you said you had the hysterectomy, they had I think 20 something fibroids. Like, what is the number of fibroids where you're just it's just better to take out the uterus? Like, or is there just is it kind of just exponential, or is it just you try to just take out as many as you can before taking out the uterus?
So that's not how we counsel patients, because there's no such thing. In the way that I practice medicine, it's not paternalistic, oh, I want you to take out your uterus because I don't think I can do it. I can't take out this many fibroids. I had a 42-year-old patient when I was in residency. It was not my patient. In residency, they're your patients, but they're not, because you don't go through the process of counseling the patient. You just see them on the day of surgery. Whatever you're signed up for, that's what you're signed up for. So we took out 69 fibroids. She did end up in the ICU. She did end up saving her uterus. And I have a picture somewhere of them all lined up. I actually should create a frame for that because that was actually really cool. But she's a Nigerian woman. The #1 incidence in the world is Nigerian. I am a Nigerian woman, so I knew I was going to have fibroids the day that I met her. And so she wanted to have her uterus because she wanted to have babies. Also, that huge uterus that you saw, that's also a Nigerian woman. Also, all the patients that you heard about were Black women. So there's no number. There is my skill limitation. So if the patient still wants to have babies, I do counsel some patients, like, you have a risk of losing your uterus because if I'm in there and there's nothing left to put together, I have to take out your uterus. I can't just leave a gaping hole there. So they know that going in. I've actually never counseled a patient, and I know I will it's just the way that it goes. I'll do enough where I get there. But I counsel them that, hey, you have a lot of fibroids. There might be no actual uterine tissue left. So, because all your cells have created fibroids. And so I'm not going to take them out. I don't think you should have a myomectomy. But if the patient really wants it, I will go in, try to do it. If I have to do a hysterectomy, I have to do a hysterectomy. So there's no such thing. We don't actually practice in like absolutes. You learn in absolutes, but we don't practice in absolutes.
Okay. Thank you. That helps a lot. Yeah. Because like I was wondering, because you had mentioned that a lot of the patients were like never been pregnant, or so I was wondering, like, at what point would you just be like, is there also like a risk for like if you are pregnant versus not pregnant that you'd have like a higher risk of developing fibroids?
Sorry, no. So what had happened is that many of these women like me are career women and haven't had babies yet. And then they actually come in because they just got married, and then they're trying to get all these other things. Maybe they've tried for a year. I'm also a unique practice in that I get a lot of referrals. So my patient base is not indicative of everyone's patient base. So I tend to get like fourth opinion, fifth opinion. Everybody where I practice, a lot of patients don't get the option of uterine sparing techniques. So that's why I get a lot of referrals. Where many women, so fibroids doesn't cause infertility, it causes subfertility. It can cause infertility based on the location, but if a fibroid is greater than 5 centimeters, 5 centimeters is the size of a strawberry. If it's bigger than that, or if it's submucosal, which means that it's pushing into the lining, then we take it out for fertility purposes, if it's solely for fertility. Or if there's unexplained fertility, meaning that we've worked up everything else and everything seems fine, but you have fibroids, we take those out. Okay. And so I've had a patient who was pregnant with like so many fibroids that I was called in to deliver the baby because I had to literally deliver the uterus and then find the backside of the uterus to do an incision to deliver the baby, because the front side of the uterus was the anterior portion of the uterus was all fibroids, but she was pregnant. And she had a 34-week fetus because the uterus went into labor thinking this is 42 week size or something like that. So the uterus only has a capacity but for so much.
Wow, that's insane. Like, I can't imagine that, but yeah. Thank you so much, Dr. Arumala.
You're welcome. Other questions?
So the big fibroids that you removed, afterwards, wouldn't it be more difficult for the patient to try and get pregnant because of scarring and stuff?
No, they don't have, it's not more, we let the uterus heal for 3 months. They have a lot of symptomatic relief. They tend to have now good tissue for a fertilized egg to implant. They have good tissue for a placenta to form. They tend to actually have better pregnancy outcomes, both anecdotally and in the literature.
Wow, that's interesting.
Questions, other questions?
So I have a question as to what's your decision tree as far as doing a laparoscopic procedure versus a open procedure abdominally?
My personal is that I start everything laparoscopically. You were very right in that, well, everything except for like, I did an MRI and your uterus is down up to your xiphoid process, like that lady that we saw, right? Like there's no way I'm gonna get that out laparoscopically because the incision that I'm gonna have to make, since we don't use the morcellator, so let me back up a little bit. The morcellator, it used to be like a little blender that used to Pac-Man up all the fibroid tissue and like suck it up. So we used to do a lot more laparoscopic surgery then. So there was a particular woman who was an anesthesiologist at Brigham and Young, which is at Harvard's hospital. And so she needed a hysterectomy and a morcellator was used in her case. The myoma that was there was actually a leiomyosarcoma. And so the morcellator seeded the cancer all over her abdomen. And so she died. And then after that, well, she's a prominent anesthesiologist at Brigham and Young. There was a very big media outburst. And then the FDA now placed a hold on morcellators. So now we can't do really big fibroids. So what we do is I actually do a cold knife core. I put the fibroids into a bag. So the biggest bag I have is a 15 centimeter bag. 15 centimeters is like because we don't really think in centimeters, a lot of us, we think in inches, but they're like 2 huge grapefruits. Like that's how big the bag is. And so if I have more than 2 huge grapefruits, I still might try, but I usually try laparoscopically if I can get in laparoscopically. And I actually do everything robotically now. I used to do laparoscopic until this year. I actually recently got my robotic certification and taught myself. So I do that laparoscopic. I try to do smaller incisions. Smaller incisions are good, not just aesthetically, but patients can go home same day. They have less use of narcotics, so less addiction. They have less side effects from, they have less bleeding because the robot magnifies depending on which robot you have, magnifies the picture by 15 to 25 times. So you can see exactly where it's bleeding and stop the bleeding. So there's usually less bleeding with with laparoscopic procedures. The robot itself, the way that it's created, if you create a hole just like this, there's the robot trocar is here. It doesn't move like this. It moves like in a very controlled manner. So there's a lot less incisional pain. You cut less nerves to get there. It's only an 8 millimeter trocar, which is like less than a blueberry width or less than the width of your finger. So those are why we use, and this is not just anecdotal, these are studies that have shown to do all of this. So I always make the decision, I always do an MRI to see where exactly are the fibroids. So I need to do a hysteroscopic approach and a laparoscopic approach. Do I need to do a laparoscopic approach alone? I do have an office hysteroscopy, so sometimes I just put it in and see if I can see a clean, pristine cavity. And then my decision tree is always to try laparoscopically because I can always open. Yeah.
Thank you.
And I have been to a couple of, there are very interesting things going on in the world in terms of trying to make smaller and smaller incisions. I recently went to some trainings for what we call like Vino. Vino is a vaginal hysterectomy that is done through, but there's a laparoscope, meaning there's an actual camera attached to it. So you can actually go in, like you would do it. A vaginal hysterectomy is blind, so it's really hard to do it with large fibroids. or endometriosis. So if you have a camera, you can actually see better, making you feel more comfortable to avoid the ureters, the tube from the kidneys to the bladder. And so they all course through. If you remember from your anatomy in the first year, you remember that we talked about water under the bridge. The bridge is the uterine arteries, water is the ureters. So we're always trying to avoid that. You know, they say that, you know, natural predator of the ureters is the gynecologist. So we try to avoid that. And so there's so many things that are out there in technology-wise that can help us make smaller and smaller incisions. So hopefully when you guys are practicing in your careers, you'll be able to make these pinpoint incisions or no incisions at all. And we need to continue to work with women's health research, particularly in surgery, to improve the techniques that we do. So I'm always learning. I'm always involved. And that was one of the reasons why I wanted to be a professor, is because I wanted to be involved with cutting research and knowing what's new, because y'all make us stay on our toes. If we don't know, you're like, well, I read this. And you're like, wait, what? When did you have time to read that? So.
Right, Dr. Myers? Well, thank you so much, Dr. Arumala. This was very, very informative. Are there any last minute thoughts or questions that anyone has before we wrap up?
I was just going to say thank you. This was a very fun presentation, and I learned a lot, so thank you.
Same. Thank you so much. I learned so much. I actually want to go into OBGYN, and this, I don't know, this was amazing. Thank you.
You're welcome. I do have one last thing. A lot of women want to go into, a lot of female medical students want to go into OBGYN, and it makes my heart really warm. I will tell you, I wanted to become a dermatologist until actually my actual 4th year. And so I want to encourage you to keep your mind open. Attend things like this that show you things that were better. If I kept my mind open, I would have learned OMT, because as a dermatologist, I'm like, I don't need to learn all that. I don't need to know all that. But keep your mind open. Learn every opportunity. You never know what will intersect and what will be helpful, because life is not as black and white and as straight path as you would like to think, because a lot of times we think we're in control of our destiny and we have absolutely no control. So keep your mind open, learn more about what OBGYN is. It is not delivering babies and seeing patients in the office. In fact, I only deliver 10% of my practice is delivering babies. So I see myself as a surgeon, a gynecologic surgeon that delivers babies here and there. And I have friends who do 90% or 100% delivering babies and will never touch a fibroid a day in their lives. So you can still actually find your niche in the certain area that you work in. I actually have a friend right now who does only incision-less surgery. So she only does vaginal hysterectomies. And so there are very many things that you can actually find your niche and make your niche. So in medical school, that is the opportunity for you to see the world and see the horizon, so you can make your decision based on information and not on sentiment.
Thank you so much for those nuggets. Well, we have class at 1.
Yes, you guys enjoy lunch. It has been really good talking to you. And I hope you guys I wish you the best. My information, I don't know, Touro, you can share it with everybody.
Yeah.
I forgot to put that on this PowerPoint, but you guys can reach out to me anytime. I'm pretty responsive.
Yeah. All right. Thank you so much.
You're
Bye.
welcome.
Thank you.
Take care. Bye.
Bye.
Yeah.